So the idea is where and what to do to reduce some fairly massive disparities in the burden of stroke. It falls disproportionately on different populations. And sort of a review of how we're doing to reduce these disparities and what we should be doing, hopefully, to reduce them more. And to provide, hopefully, a framework to guide efforts. By the way, the only reason to do disparities research is to make a difference. You know, if it's not to describe the differences, but hopefully to reduce them. And so what can we do to make these disparities smaller? I have nothing to disclose. And so this lecture is broken into two parts. The first is where should we be targeting our efforts? And the second part is what should we be doing there to make a difference? So I come bearing good news. This is the pattern of age-adjusted stroke mortality for stroke over the last 20-ish years. And as you can see, this is for whites. There's been this phenomenal decline from about 170 per 100,000 down to 100 per 100,000. So 40% decline in stroke mortality over 20 years. It's one of the great accomplishments of public health, in my opinion. You can see it's plateaued recently, but still there are these wonderful declines in stroke mortality over the last 20 years. Unfortunately, this is the same pattern for African Americans. And as you can see, it's the same type of decline, but two notable differences. One, it's substantially higher. And the second is that while it looks like it's plateauing in whites, recently it might actually be increasing a bit in African Americans. If you look at other race ethnic groups, Hispanics, Asians, and Native Americans all fall below the mortality rates of whites. And so if you talk about race ethnic disparities in stroke, you're largely talking about African Americans. So in 2010, way back here in 2000, they set the 2010 goals for the Healthy Persons 2010. And it only had two goals. And the second of those was to eliminate disparities, not to reduce, but to eliminate disparities. And so how are we doing? This is the mortality ratio compared to whites. And you can see that here are African Americans, and in 1999, there was a 36% excess mortality in African Americans. And over this 20-year period, we have eliminated that 36% excess all the way down to a 43% excess. And so while mortality is dropping in all race ethnic groups, actually the magnitude of the racial ethnic differences in stroke have increased from 36 to 43%. And so not only did we not eliminate it, but we moved in the wrong direction. And to make things even more depressing, if you look back as far as you can, as far as the data go back, and between 1949 and 1951, the white to non-white, by the way, at that time, non-white in America was largely Black, stroke mortality ratio was 1.63 for men and 1.92 for women. And so we've made actually very little progress to reduce the racial disparity in stroke over the last 70 years. And so this is a great success that is shared by everyone, nestled with a complete failure to reduce the racial disparity in African Americans. But it turns out that's actually the good news for African Americans. And when you look at the age-specific rates shown on this group, and so this is Blacks compared to whites, you can see that there's not a 40% excess for the ages 45, 55, and 65, but 100 to 150% excess. And so Blacks age 45 to 54, the death rate is actually 2.5 times, not 1.4 times, but 2.5 times higher. So immense disparities. And when you look at other race ethnic groups compared to whites, you can see that basically there's virtually no disparity for any other group. And so if you talk really about race ethnic disparities in stroke, you're talking about young Blacks. Young Blacks below, by the way, young, if you're my age, is now being defined as less than 74, which is good for people my age. And I would like to ask you for this lecture, if you'd please remember this pattern of Black-white differences in mortality. Specifically, I'd like you to remember that, that it was 2.5 times bigger at ages 45 to 54. And that there was it decreases with age. And by age 80, the disparity sort of goes away. We'll come back to that later in the lecture. So, so what do we know and what do we need to know to reduce that disparity? And so what we know very well is that the disparity exists on stroke mortality, deaths from stroke. But stroke mortality is actually comprised of two components. The first component is incidence of stroke, how many people are having stroke. And the second component is case fatality, how many people, once you have a stroke, die of it. And so it raises the question, is this excess mortality in African Americans, is it because more Blacks are having strokes, or is it because Blacks are more likely to die once they have a stroke? Or both, could be both. And what does that have to do with targeting interventions? If we're going to make a difference, why do we care if it's incidence or case fatality? And of course, the answer for that is that if it is incidence that's driving the disparity, then what we need to do to make a difference is to focus on pre-stroke prevention in the general population. Specifically, what can we do to stop African Americans from having more strokes? So, so this becomes now a population issue. Alternatively, if what the difference is the case fatality, then what we need to do is to focus on improving healthcare in the hospital so that we can have better outcomes from African Americans who are having stroke. It could be that they're not receiving the care that supports their recovery in the hospital, so they're more likely to die. And so basically, this really comes down to whether we need to be working in the community or in the hospital to reduce these disparities. We'll be addressing all of this, and really for this entire lecture, almost all the data I'll be presenting is from this REGARD study that Sadiq referred to earlier. Just very, very briefly, just for this lecture, it's a general population study with very diverse aims. It does a lot of different things. But for today, it's a general, what we did was recruit people through a combination of telephone and mail, and then conducted a telephone interview with them. And as you can see here, we've recruited about 30,000 people. It's very geographically heterogeneous. But 56% of the people are from the stroke belt, these 8 southern states down here in the southeast. You can see that we oversampled. It's North Carolina, South Carolina, Georgia, Alabama, Mississippi, Tennessee, Arkansas, and Louisiana. So over half of the people came from those 8 states. And we also oversampled African American, because what we're interested in, obviously by the name of the study, are the racial and geographic disparities. The trick of regards, because the question, do you have undiagnosed hypertension, has always been a really ineffective research question. And so the trick of regards is we partnered with companies that do life insurance physicals and sent a health professional, mainly nurses, into the home. And in the home, we did a very brief physical, venipuncture, got blood and urine, and did an ECG, did a few other things like went in the medicine cabinet and found out what medicines they were on and such. And so the unique part of regards is that it's a national study, geographically heterogeneous, but with direct measures of risk factors, which makes it a fairly unique study. We then have been following these people. By the way, I should have said early on that they were recruited between 2003 and 2007. So we've been following them at 6-month intervals by telephone. We initially for surveillance for stroke events, A lot of other outcomes have been added. And so basically, if there's a suspected stroke, what we do is go retrieve the medical records, bring them back to UAB, and a panel of primarily neurologists go over them to adjudicate whether there was a stroke and what type of stroke it was. And importantly for this lecture, it then provides measures of both stroke incidence, and because we're following the people, including after the stroke, the case fatality. So, and so this gives a unique opportunity to directly address this question for the racial disparity in stroke. Is it incidence or is it case fatality? So for the first part of this, which is trying to answer exactly that question, is the disparity incidence or case fatality? There's really two separate analyses that I'll be presenting, and we do this over and over again for the different disparities. The first focuses on incidence, and for that analysis, the primary outcome is whether or not a subsequent stroke occurred in these people who were stroke-free at baseline. And what you'll be seeing is a lot of proportional hazards analysis of that, and I hope you're comfortable with that approach, because that's what you'll be hearing about. The second analysis is case fatality. And so what we do for this analysis is, among that subgroup that had a stroke, we did a logistic regression to see what are the predictors of dying within 30 days of that incident stroke event. In both cases, we assessed interactions with age, race, and sex. And if there was an interaction significant at the 0.1 level, we considered that sufficient evidence to stratify the data and look within the age, race, or sex strata. And love to talk more about the 10% choice, but that's not really that's the geeky statistician part of me. So here are the black to white hazard ratios. Turns out there was a highly significant interaction with age for stroke incidence. So we've changed now from talking about mortality, dying from a stroke, to stroke incidence, having a stroke. And I hope this pattern looks familiar to you. So, and basically we're now focusing on incidence again. And basically the pattern of stroke incidence nearly perfectly mirrors the pattern that you saw earlier that I asked you to remember for mortality, where at age 45, you're at basically 2.5 times higher risk of having a stroke. And with increasing age, that excess risk in African Americans decreases, so that by age 85, there is no racial disparity. So you're getting exactly the same picture for incidences as mortality, strongly supporting the idea that incidence is playing a critical role contributing to those mortality differences. Exactly the same estimates. Shifting gears now and focusing on case fatality, black-white differences in case fatality. So what we did was examine the case fatality 30 days after a stroke. There were no interactions with age, race, and sex here, so we could look at main effects. And when you do that, what you come up with is that you're more likely to die if you're old. Being male or female had no impact. The 95% confidence limits included one. And also importantly, race was not associated with the chance of dying after a stroke. And so in summary, what we have is a perfectly mirrored pattern suggesting that incidence is playing a major role, while case fatality is not important at all. And so if we're going to attack the black-white differences in stroke, we need to be focusing on reducing the black excess incidence, which means that we need to be working in the community, not the hospital. So what I'd like to do now is change gears a bit and look at a different disparity in stroke. And now we're shifting to urban-rural disparities instead of racial disparities. Same kind of game, going to do exactly the same thing again. And if we do that, here is the stroke mortality in the most urban areas, the large central metro counties. And if you compare that to the large fringe metros, you see almost no difference. You're coming up with exactly the same stroke mortality. But when we move into the medium metro, you can begin to see this slightly higher risk of dying if you're in the medium metro, higher still if you're in a small metro, higher still if you're in a micropolitan, and about the same if you're in a non-core. So if you look at the mortality ratios, you can see this is compared to the large central metro. You can see that in the more rural areas, we started with about an 16 or 18% excess risk of dying from a stroke if you're in a rural area. It increased up to about 28% higher risk around 2010. But since then, for reasons that I'll tell you are completely not understood, it has been decreasing so that by 2018, we're back down to roughly where we began, but still, a sizable, 8 to 12% higher risk of dying of a stroke if you're in a rural area. Playing the same game again, is that because of there's a higher incidence of stroke? One of the advantages of regards, by the way, which very few studies have, is we have a goodly number of people from rural areas. And that's because of this geographic heterogeneity that we had. And you can see that if you are compared to being in an urban area, if you're from a large rural area, you have 23% higher risk, and it is significantly higher of having a stroke. This is stroke incidence. And if you're from a small rural city or town or an isolated area, living out truly in the country, there's a 30% higher risk of having a stroke. And that trend is highly statistically significant. And so as you move from the urban areas out into the country, you're at higher risk of having a stroke. Again, the same game. How about case fatality? Of the people, compared to people who had a stroke in an urban area, if you had a stroke and you lived in a large rural city, there was an increased risk, but as you can see, the 95% confidence limits include 1, and so it's a non-significant increase. And if you live in a small rural town, there's actually a non-significantly lower risk of dying if you have a stroke. And there is no evidence of a trend across these levels of rurality. And so basically what we have is something that, like race, the urban-rural disparities in stroke seem to be largely driven by a higher incidence rather than a higher case fatality. And so again, if we want to attack these urban-rural differences, really what we need to do is to be working in the rural areas to prevent people from having more stroke, rather than in the urban, rather than working in the hospitals for better care. By the way, it is very true that in rural areas, the healthcare for stroke patients is much worse. You're less likely to be seen by what's called a primary stroke center. You're less likely to get ultrasound evaluations. You're less likely to get your arteries cleaned by TPA. And so I'm not saying there are not disparities in the care of stroke patients. Really what I'm saying is if we fix those, that's not why the urban-rural disparity in mortality exists. So chances are it won't fix that urban-rural disparity in mortality. Let's change gears and look at a different geographical disparity, one that is, has been a lot of my career, looking at what is called the stroke belt. By the way, people don't look at these legends a lot. I'm going to blow it up so you have to look at it. And on this map, the areas that are light purple have stroke rates that are roughly 50 per 100,000. And the dark purple is roughly 150 per 100,000. And so as you travel around America, there are threefold differences in the risk of dying of a stroke, which is really remarkable. And basically this area that I've circled in red, the states are listed over here, this 8-state region, is frequently referred to as the stroke belt, which has really, really high levels of stroke. And by the way, the coastal plain of North Carolina, South Carolina, and Georgia up and down this right down by the ocean, really has the highest stroke mortality in the nation. And I'm from a little town, Tarboro, North Carolina, which is right there, which is the county seat of Edgecombe County, which every year is in the top 5 counties in the nation for stroke, which is probably one of the reasons I got interested in this. So again, the same game. What are the patterns of mortality? You know, here is the stroke mortality if you're not part of the stroke belt. Again, the same decline. And here's the pattern if you're part of the stroke belt. Here's the mortality ratio. So way back in 1999, we had a mortality of about 28% higher. And over these 20 years, that it remained, despite the declines, it has remained incredibly persistent. It's still 28%. So over the last 20 years, we've made zero difference in reducing this disparity, which, by the way, strikes Alabama heavily also. So again, the same games. Is that because of incidence or is that because of case fatality? So here are the incidents as we move from the counties that have the highest mortality, I beg your pardon, lowest mortality to the highest mortality. So this is basically non-stroke belt and stroke belt counties. And as you can see, we start out with compared to people in the lowest mortality, the non-stroke belt counties. If we move up to counties that have a little bit higher mortality, the stroke incidence is also higher. As we move to counties that are higher still in mortality, it goes up more. And if you go up to the counties with the highest stroke mortality, dying from stroke, you can see that it's 29% higher and it's statistically significant. And the trend test is, no doubt about it, the counties with high stroke mortality are the counties with high stroke incidence also. However, if we look at the case fatality, now adding this, a very funny pattern emerges. So again, this is compared to people who have a stroke and are living in a county with low stroke mortality. If I live in a county that is just a little bit higher stroke mortality, I am actually more likely to die from that stroke. It jumps up to 60% higher chance, almost 70% chance higher of dying of the stroke. But when I move to the third quartile, you can see it goes back down, and then the fourth quartile, it goes back up. So you have this really inconsistent pattern with the relationship between living in an area where lots of people are dying from a stroke and actually dying from the stroke if you live there. And the p-value for the trend is there increasing risk of dying from a stroke as you move up from areas where few people die from a stroke to lots of people die of a stroke is a borderline significance. I've never believed in the 0.05, and so I consider this modest to moderate evidence that case fatality could be playing a role. And so in summary, basically both the racial and geographic, both the urban, rural, and regional differences in stroke mortality, it's pretty clear that they're being driven by incidence. Hence for all three of these, we really need to focus on factors that contribute to the disparities in the incidence of stroke, which really requires us to move out of the hospital. We need to be thinking not as clinicians and back to the community level, or at least to the primary care level. Like our dean is, working back to being internal medicine or family practice type doctors, not neurologist type doctors. And the racial disparity is really focused almost completely in the African Americans less than 75 years old. And so we really need to be focusing on what is driving stroke in African Americans under the age of 75. Case fatality might be playing a role in specific counties with high mortality, that stroke belt, stroke buckle. And so there is some hope there to make a difference, but it is a smaller and less consistent effect than we're seeing for incidence. And I'll stop there and see if there are any questions. By the way, more work needs to be done to understand. By the way, you can't give a talk without the phrase more work needs to be done, but more work needs to be done to understand what aspects of stroke care might be contributing to that, the higher stroke mortality in these high risk regions. But I want to stop for a minute and see if there are any questions about that, because I'd like to change gears now and say, what can we do in those different areas to make a difference? And by the way, Sudeep, I'm projecting the slides, so I don't see the talk. And if anybody is chatting with me, the way this is projected, I cannot see it. So
not yet. I don't see anybody there yet, probably because in the beginning I mentioned that we'll take questions at the end.
That's great. That's great. We'll do that. So what I want to do now is completely change the topic. What I want to do now is to say, if we are going to focus primarily on incidence and a little bit on case fatality, what do we need to do to make a difference? And I want to start out by saying, I think we need a new approach. What we're doing is those disparities are not decreasing. Despite our success in decreasing stroke overall, we've had no impact on the thing. And so basically we've had great success in reducing deaths from stroke. We rock star, 40% decline in 20 years. It's amazing. And so the good news is that this success has been shared by all groups. That's wonderful. But nested in that good news is the bad news, which is if it's shared by all the groups, then we've had no success in reducing the disparities. What we've done is make everybody better while perfectly preserving all the disparities. So we've succeeded in reducing the burden of stroke while maintaining the stroke disparities. African Americans, rural people, and Southerners are still at the higher risk despite these dramatic declines. And so I'm going to suggest that we really need to change the question and our goals. And what we need to do is to identify specific interventions that are focused not on reducing stroke, but on reducing stroke disparities. And I'd like to suggest there are several approaches where we could focus on the disparities. And I'm going to give examples of each of these. So this is going to seem a little bit obtuse for a second. But what we could do is identify factors where the care is failing in the more vulnerable groups. In other words, where basically where care is not working well in African Americans. Alternatively, a second pathway is we could identify factors with both a similar impact on stroke risk in the less vulnerable group and the more vulnerable groups. In other words, this makes everybody better, but where there's a higher prevalence in the more vulnerable group. And the reason, and we'll talk about this, but if what we do reduces stroke for everybody, but African Americans have a lot more of the condition, then that's going to help African Americans more than it'll help non-African Americans. And finally, we can identify factors that have a larger impact in the more vulnerable group. And what we need to do is to be very strategic. We need to be thinking this way or some way where we're trying to target making a difference on the disparities, not making a difference, but making a difference on the disparities. So what I'd like to do now is to give examples of each of these, because helping everybody is a good thing, but helping everybody will maintain the disparity. And if our goal is to reduce the disparity, we need to be thinking differently. So now an example of each of these 3 points. So the first thing is to identify factors where care is failing in the more vulnerable group. This is the first pathway that I'm proposing. And I'll say the great joy of doing research is being wrong. There's nothing more fun than thinking you know what's going on and finding out that you're wrong. And this is an example where I could not have been more wrong, almost prejudiced in the way that I was thinking about this, because I started out thinking that with the lower average educational level for African Americans, their health literacy would be less. And working to improve the health literacy could have a positive impact on health of African Americans, because there would be a health literacy gap there. Turns out hypertension is the largest stroke risk factor. Mine and Virginia Howard, my research partner's old medical mentor, used to say there are 5 risk factors for stroke: hypertension, 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 and some other stuff. And so hypertension is what really matters. So let's look. I thought that African Americans would be less, hypertensive African Americans would be less aware that they have hypertension. But when we went out and looked in regards, what we actually saw was that this is the black to white ratio, or really odds, of being aware of hypertension if you have hypertension. And so it turns out African Americans are actually more, who are hypertensive. Let me do that again, I messed up. Hypertensive African Americans are about 45% higher odds of knowing that they have the hypertension. It's not that they're not less aware, they're actually significantly more aware of their hypertension. And so then I thought, well, gee, they don't have the resources and access to healthcare. Maybe they're not being treated for their hypertension. And when we looked at the hypertension, the treatment for hypertension, so among people who have hypertension and know they have it, are Blacks more likely or less likely to be treated? And I was going to guess less likely. But when we look, it turns out they're actually significantly more likely to be treated for their hypertension. So it's not awareness and it's not treatment. And then finally, if you are hypertensive and you know it and you're on treatment, are you treated to guidelines, or is your hypertension under control? And when you look there, there are huge gaps, with African Americans being significantly less likely to have their hypertension controlled. And so if we're going to try, by the way, the Heart Association used to have a program called Know Your Numbers. And the idea of this was, we're going to help African Americans by telling people that they need to be more aware of their blood pressure levels. But it turns out that improving hypertension awareness and treatment is not going to have an effect on reducing the disparity. In fact, if we're successful in improving awareness and treatment, it's going to make the disparity bigger. It'll help people, but the disparity will get bigger, because who we're going to be impacting are whites who are not aware and whites who are not treated. On the other hand, we do need to figure out what we can do to improve the hypertension control in African Americans. Powerful people like Paul Muntner are working diligently to try to solve exactly this problem. What is it about African Americans that leads to poor control? And so the first idea is identify this group where the care is failing. So blood pressure control, if we can fix that in African Americans, we can reduce this disparity. That's the first way we can do it. The second way is to identify factors with both. It has to have both of these, by the way, where the impact on stroke risk is the same for Blacks and whites, or rural, urban, or Southerners, non-Southerners, but there's a higher prevalence in the more vulnerable group. There's more of it in Blacks, there's more of it in the rural areas, and there's more of it in the South. And so what we have here is a table. We have the demographic factors, traditional demographic factors, what are considered the traditional risk factors, frequently referred to as the Framingham risk factors, in socioeconomic status. And so focusing first on diabetes, you can see that among people who had a stroke, 25%, 26% of the people were diabetic, compared to only 21% in people who don't have a stroke. And Blacks have a lot more diabetes than whites. And so if we do something to improve diabetes care, it's going to reduce stroke, and it's going to affect 30% of the Blacks and 15% of the whites, which will reduce the disparity. Likewise, if I look at education, people who have a high school education or less, much more common in people who have strokes than not. And Blacks have a lot bigger disparity, have a lot larger prevalence of low education. Making a difference there will make a difference on the disparity. In contrast, if I look at atrial fib, AFib is a huge risk factor for stroke. It's almost twice as more common in people who have a stroke, but Blacks have less of it. So if we improve AFib care, again, we will make the disparity bigger, not smaller. So that is not the target. So you can look at this and say that where we need to be focusing is on blood pressure. You can see these huge differences in blood pressure. These differences in smoking will make a difference. And so we need to target those things that African Americans carry a heavier prevalent burden of. So the final thing is so here's the Black to white incidence in stroke, and you can see it's declining. And if I adjust for those traditional risk factors and SES, then that curve, if it explains all of the difference, it would go down and it would be flat. This is called mediation analysis. It would completely explain the differences. So what happens if I adjust for the Framingham stroke risk factors and SES? I go from the brown line to the blue line. And so if I'm successful in improving those factors, I can reduce the Black-white differences in stroke by 50%. So basically, adjustment for these risk factors attenuates the association by roughly 50%. Basically, half the disparity is attributable to those risk factors. And so basically, what can be done to address that half full portion, the portion that I understand is related to those risk factors? Well, most risk factors, hypertension, diabetes, we're examining prevalent disease, whether it's present or absent, not the effectiveness of treatment. I'm not talking about blood pressure control. I'm talking about, do you have prevalent hypertension? And that implies that risk factor treatment is not the key, but risk factor prevention. We need to get out in the community and stop African Americans from developing hypertension and diabetes in the first place. And it suggests that really we need to shift our focus, if we're going to attack this disparity, from racial disparities in stroke and change that to racial disparities in stroke risk factor prevention. Really quickly, my wife has reminded me that I'm running slower than I predicted. But anyway, so the third approach is to identify factors that have a larger impact as effect modification by the race or region. So this is the change in stroke risk. Vertical axis is hazard ratio for stroke for a 10 millimeter difference in blood pressure. And so if I reduce blood pressure by 10 millimeters, this suggests that there'll be about a 14% reduction in stroke risk. But if I look at that by race, it turns out that there's an 8% reduction in whites, but a 24% reduction in Blacks. So the same 10 millimeter difference in stroke, in blood pressure, is associated with an 8% increase in whites, but a 3 times larger 24% reduction in Blacks. And so for factors where Blacks are differentially susceptible, or Southerners or rural people are differentially susceptible, the same treatment is going to have a bigger impact in the African American or the Southern or the rural population than the low risk population. So what are the implications of this differential susceptibility? Well, consider the Black-white differences in stroke risk stratified by age, race, and systolic blood pressure. I'm going to stratify age as being less than 65. The main thing I'm interested in, 65 to 74, some interest. Greater than 75, I'm not really interested. And then also simultaneously stratified by systolic blood pressure, sort of using JNC7 categories, normotensive, prehypertensive, and hypertension. And remember, it's the risk of this low group that I'm mainly interested in. So what's shown on this graph is the black and white stroke risk in young people who are less than 65 who are normotensive. And you can see, despite the fact that there's a huge excess risk in Blacks under the age of 65, there's really no disparity in Blacks that are less than 65 who are normotensive. This is the impact of that differential susceptibility. In fact, the hazard ratio is actually less than 1. Blacks are at lower risk. The red line is the whites. So the whites are having more stroke among young normotensive people compared to Blacks. Well, I'm going to take that graph and I'm going to stick it right here and say, well, how about other normotensive people? Well, regardless of the age, you can see there's virtually no racial disparity among normotensive people. Once you're normotensive, that disparity goes away. How about people who are pre-hypertensive, people 120 to 139? Well, that blue line, the African Americans, is beginning to come down in these younger people where the disparity in mortality really exists. 40% increased risk, 26% increased risk. If I look in people who have stage 1 hypertension, that's where the disparity just explodes. So what you're seeing here is the impact of that differential susceptibility. If you look across this, the red line is not that influenced all that much by how much hypertension you have. But boy, that blue line is just taking a dive. And so that's a target to reduce the disparity. So overall conclusions for the whole talk. We've had great success in reducing overall stroke mortality. As I've said, one of the great public health achievements, but we have failed miserably at reducing stroke disparities. I'm suggesting that to win on this battle, we need a new paradigm. And the first thing is we need to think about where to focus our interventions to reduce the disparities. And it appears to be driven primarily by incidence rather than case fatality. And so all of us are in the right business in public health. We need to be focused on targets to reduce incidence, which will require community-based interventions. Reducing disparities in stroke treatment is a noble effort, and I'm not saying not to worry about that. I think African Americans and Southerners should receive the best health care. But if we're successful at that, it probably will not reduce the disparities. Once we say we're going to focus on these community efforts, what we need to do? And a general reduction in stroke risk is good. I'm not saying I don't care about that, but in itself, it will have no impact on the disparities. If we want to have the impact on the disparities, we need to be strategic and target our interventions on the disparities, not reducing the burden of stroke, but reducing the burden of stroke in these high-risk groups. We do that by targeting areas where we're failing in treatment, targeting areas where the high-risk group has a higher prevalence, and targeting areas where the high-risk group has a higher susceptibility. Continuing to do the same thing and expecting a different outcome is insane and wasteful. And so with that, that's really the end of it. Thanks. The data presented are almost completely from the REGARD study, and the heroes of the talk are really the 30,000 participants in the study. And a wonderful team of collaborators, as I've said, led now by Suzanne Judd. The study could not have been done without the strong support of NINDS and co-funding by Aging. Wonderful support from people, and I close where I began. Thank you for having me here.